Welcome, everybody. I'm Kinar Javeri. I'm a professor of medicine at New York, and I welcome you on behalf of Dr. Jain, who is in UNC, and Dr. Bansal in Vedanta in India, to the Indian Society of Nephrology and International Society of Glomerular Disease webinar on advances in podocytopathy. Thank you all for joining. We have a packed agenda today with some renowned speakers like Dr. Radhakrishnan, Dr. Arora, and Dr. Ramachandran. And then we have a panelist discussion of cases following that by Dr. Jain and Dr. Bakchi and several of the other faculty. So stay tuned till the end. We will have a very packed and fun agenda on discussing podocytopathies. Just in terms of housekeeping, for all questions, we would like to use the chat feature. So please put all your questions through that, and one of us will screen them and ask them to the speaker. We would also ask everybody to be muted. I would also like to put a plug in for the International Society of Glomerular Diseases. And if people from India want to join for free, and let's double the ISGD membership in India today. We'd like to begin now the webinar. So the first speaker for today is going to be Dr. Radhakrishnan. He's going to be talking about minimal change disease. Dr. Radhakrishnan does not need any introduction. He is the professor and the ultimate professor of glomerular diseases at Columbia and probably the world. And he is now the new editor-in-chief of Kidney International. So with that introduction, I would like Dr. Radhakrishnan to share his slides and begin the talk on minimal change disease.
Thank you, Kenar. Real pleasure. And I will immediately join the Glomerular Disease Society immediately, right? So hope all of us can join. I think this is a great opportunity to spread the word on GNs. Okay, today's topic is on minimal change disease. I'll make this short because there's only one new development, and that's anti-nephrin antibodies. So the treatment has been unchanged for many years, maybe a decade or two, but let's talk a little bit about anti-nephrin. So the objectives of this talk are the pathogenesis, the clinical features, which most of you are very well aware of, and a very brief look at treatment approaches. So since this is a podocyte conference, the way I look at podocytopathies is to look at the extent of damage, right? If there's no change in the podocyte number after the injury, and there's no changes in histology, we call this minimal change. On the right side is when the podocytes are de-differentiated, and because of the proliferation, it can lead to collapsing glomerulopathy. In children, this is an entity called DMS. And in the middle is scarring. So there are loss of podocytes and death, and that leads to the exposure of the GBM to the parietal epithelial cells, and scar forms, and that's FSGS. So some people think this is a spectrum, but we have now biomarkers that can actually separate these entities quite well. So this obviously the main problem here is without an EM, it's almost impossible to make a clinical diagnosis with light microscopy. So with EM, we get a lot of food process effacement and a completely normal or a near normal light microscopy. But there's a key here, which a lot of us have been ignoring for years, is that this is considered as a negative immunofluorescence. And really what happens is that story is being developed in terms of the anti-nephrin antibodies syndrome. So here, most of the adult patients present at about 45 years. This is the Columbia series. They have albumin is low, cholesterol is high, and most of them are very nephrotic, right? In fact, 30% have microhematuria, and some of them actually need dialysis on presentation. So the other folks that we see in the adult clinic are people who have had children who've had steroid-sensitive nephrotic syndrome, and they move into adulthood. And if you look at this cohort of 100 patients, 100 children, the risk is about 43% of relapse, even while they're adults. And the only predictive factor is the number of relapses during childhood. So kids who are relapsing during childhood will almost invariably get at least one or more relapses during adulthood. And the sad part is that because of steroid exposure, the majority have problems with bone loss weight gain, and short stature. So this is a population that we are seeing increasingly in the adult clinics. So the pathogenesis is to find what's called secondary minimal change disease is rare. And the one entity that we sometimes look for is a thymoma, because that has got an association with minimal change disease, and many of these are steroid refractory. So if you get an initial minimal change and you're refractory, it's probably worth looking with a chest CT for a thymoma. All the others have been described. Interferon has been also associated with podocytopathies, especially the collapsing form, but some of them can present with minimal change disease. There's a distinct association with other autoimmune diseases, lupus and IgA nephropathy. And the important point is that these patients may have a lot of food process effacement, but the way you define, say, a lupus podocytopathy or a IgA podocytopathy is that the proliferation has to be the minimum level or negative, despite the immunofluorescence that is positive for lupus as well as IgA. So to call this lupus or IgA podocytopathy, we have to be very clear that there's no signs of really active proliferative lupus or IgA nephropathy. Okay, so this is the story that has led to the discovery of antinephrine. A lot of times this little dusting that you see along the podocytes was thought to be non-specific trapping. But Astrid Beans and her group at Harvard looked at sort of what is it that's causing this dusting? Is it really pathogenic, or is it just an epiphenomena? So if you look at the discovery was essentially looking for components of the slit diaphragm. They looked at antinephrine to start with, and they in fact found that there was nice co-localization of the antibodies to nephrin along with the synaptopodin, which is a podocyte-specific protein. And if you look at the presence of this in minimal change disease, and this is the Neptune cohort, at the time of investigation, about 1/3 of these patients were positive during the active phase. And interestingly, these antibodies disappeared during remission. So this was the first report, and this was confirmed by Toby Huber and his group. And if you look at a whole host of diseases, you can see that MCD accounts for 40% of positivity, and much less, of course, is primary FSGS, and it's virtually not seen in the other proliferative GS. And if you look at the prevalence in specifically in MCD who are nephrotic, and who have not received immunosuppression, you're actually looking at much higher levels, between 60 and 70%. And finally, when you look at children, it goes even higher. So kids who first present, you're hitting about 90% of these are positive for antinephrine, and compared to the whole population. So this is a very strong signal, and it correlates nicely at the bottom with the ACR, the serum albumin, and the cholesterol levels, and does not correlate with GFR. So the story is now sort of, I'm going to say, more or less established. There's one study from Dr. Ramuzzi's group who did not find this association, but every group that have looked at it has found this association to a variable degree. Now, it's also very interesting, this group from Japan looked at recurrent FSGS, and they found that in a significant number, you can see this panel on the right, that these patients had high titers of antinephrine antibodies. And if you look at essentially the whole story in terms of co-localization, you can see identical to what we found with Toby Huber's and Astrid Beans' thing. So in recurrent FSGS2, now if you can get this biomarker positive, you can measure it, you can do your therapy with B-cell therapies and plasma exchange, and actually look for a reduction of these titers, which does correlate with the improvement of proteinuria. So coming to treatment, and back in 2021, when we looked at the evidence for KDIGO, it was very soft, because the data on RCTs and minimal change disease at that time was very few. And again, mainly through extrapolation from childhood studies, the drug of choice would be corticosteroids. And if your contraindications are present, you have a choice of cyclophosphamide CNIs, MMF, or MPA, and in some patients, rituximab. So the idea is how long? you go into remission, and then after going to remission, you go into 2 weeks of you start tapering after 2 weeks from then, and then the dose and the route and all are left really up to the practitioner. And then again, initial therapy in patients, say who are obese or psychiatric issues, you can use cyclophosphamide, CNI, or MMF. There are case reports mainly, and there are some RCTs, mainly in children that have been extrapolated to adults. So here's a way to reduce, for example, steroid exposure. So this is a study that looked at, if you look at the bottom left, you're halving the dose of steroids, 0.5 milligram per kilo, plus tacrolimus in this group, levels between 5 and 10, and the control group is mg per kilo. And then once they go into remission, you taper, you reduce tacrolimus, you taper steroids by 5 mg per week, and here also you use tapering. So for the same level of, for each of these protocols, you're looking at essentially an identical remission rates. Up here you can see 79 and 76, and the relapse is a little bit quicker. Okay, so in this, the number of people who relapse is smaller in the group that receive the combo. So one approach to reduce steroid exposure is to add on a CNI. The other approach is to use tacro as monotherapy. So this is a group from England, and you can see tacro versus pred. Looking at remission rates, no difference when you go throughout from 8 to 26 weeks, and the relapse rates are also identical. So at least in my practice, I've essentially stopped using steroids completely in patients who present with either the initial presentation or in a relapse situation. So the other way to reduce steroid exposure is if you don't want to use tacro, say the patient has AKI, you can use low-dose steroids, 0.5 milligram per kilo with okay, and that's 720 milligrams BID. And you compare that with 1 milligram per kilo. This is a French study, and you can see that your remission rates are very, very similar, as are the relapse rates. And for some reason in this population, there were actually an interesting number of deaths from unrelated causes. So the point here is that you can easily reduce exposure using any of these regimens, or you can use tacrolimus alone in the initial therapy or when patients come in after a long period of being in remission. Now, this is another interesting study. It's not really a study. It's a compilation of cases, right? And they said, let's not use anything, just rituximab, right? And they just give once or maybe twice of the 375 milligram per meter square. This is from China. And they just followed these patients. And if you look at their remission, most of them did go into remission, complete for the most part, a couple of partials, and 2 patients did not respond to this therapy. So in the patients who are, if rituximab is available and you don't want to expose them to any steroids, what I typically do is I start them on either prednisone, a very, very short duration, maybe a month, or tacrolimus, prednisone in patients of AKI, tacrolimus in patients who do not have AKI. And once they're in remission, which is typically within 2 to 4 weeks, I take them off very, very quickly of these 2 drugs and keep them on maintenance rituximab for some length of time, usually 6 months to a year. If they come back in relapse, there's identical treatment. If you're following these patients long-term, you should know that the risk of relapse is significant. So over a period of 24 weeks, actually 40% of patients in our series relapse. So, and that is one reason, and you'll see that rituximab may be the go-to drug now, very early in the therapy of these diseases, rather than keeping on exposing patients to lots of steroids during their relapsing and remitting phase. So when you look at the group of patients who are frequently relapsing or are dependent on steroids, we need to know how to define them. So frequent relapses, again, this is totally arbitrary. 2 or more relapses within 6 months or 4 or more during 12 months. Now, this is a very liberal definition. At least in my mind, we really need to be very, very cautious that patients don't keep relapsing. versus placebo, there was a dramatic change in the outcome in terms of relapse-free rate by 49 weeks. So this drug is being tested, at least now, in RCT in adults. It has been tested in children and is shown to be quite effective. So this is a cohort study that we were part of. It was done by Andreas Kronbichler and his company. So the idea is that you look at patients who had difficult to treat nephrotic syndrome, FSGS, or minimal change disease. And this is the group I want to focus on, this 70% of people who are steroid dependent or frequently relapsing in either of these entities, right? And the good news is that with rituximab, 80% had either complete or partial remission at 6 months. And then 55% of people who responded remained in a relapse-free situation at 3 years. So when you look at the number of relapses too, it had gone from 1 per year to 0.17 per year. So again, just from an observational study standpoint, it is a very good drug to prevent relapses and also to treat patients who are in relapse. So the other way to limit cost is to say, okay, let's give rituximab and give them MMF to maintain the remission compared to placebo. So you can see for some time you are maintaining remission, but eventually it peters off. So you can probably get a few months without relapse with MMF, which we now know is not a great drug to prevent relapse in this group. And rituximab is definitely superior. So in the nephrin era, I think you need to, if this test becomes widely available like PLA2R, we can probably look at a biomarker-based strategy. So if you're positive and there's no contraindication to B-cell depletion, the first drug could be rituximab with a very short exposure to steroids, which I'm doing right now, and maybe tacrolimus if you're even if then you don't want to give patients steroids. And if there are any contraindications to B-cell, of course, you go with the tried and true. And then if you are negative, and again, steroids probably are cheap and very effective. And if you don't like to use them, of course, you have the same choices. Why rituximab? Because it's being now reported, I didn't show the slides, there are other slit diaphragm proteins which are against which antibodies are formed. Now, the data are not being validated, so I didn't show the slides, but there is a lot of discovery going on in that space in people who are nephrin negative. What else can cause this minimal change disease type of podocytopathy? So to conclude, the hot biomarker is anti-nephrin antibody, and I'm hoping will become commercially available for us to use in the clinic. Most of these patients are treatment responsive, but there's a significant relapse rate. If you go into full remission, it's a good prognosis. First line, at least KDIGO, and based on the data, are still corticosteroids, but increasingly, MMF, tacrolimus, especially tacrolimus, are the CNIs are being used as initial therapy. And there may be a role for rituximab based on how the nephrin story plays out. And those who need medications, corticosteroids, for example, or are frequently relapsing, rituximab is probably the go-to drug right now, with the options of MMF, CNIs, and cyclosporin also being available. So I thank you for your attention and happy to take questions.
Thank you so much, Dr. Radhakrishnan. There's actually a variety of questions in the chat, really interesting ones. The first one from Dr. Bansal saying that how long would you give a CNI if you're doing the treatment with or without steroids? Like, what is the duration?
Yeah, right. So, the reality is that in most of these patients, if you stop too early, they'll relapse. And in the patients who you do not stop too early, they'll relapse, right? So in adult patients, you might be lucky. You give a CNI for maybe 4 months, start tapering. So if your levels of tacrolimus are sort of 7 to 8, start slowly going down on the levels over the next 3 to 4 months. And what typically happens is that patient starts, getting proteinuria. I always use a home dipstick. Okay, that's the best way to prevent a full-blown relapse. All the patients get a home dipstick. They do it every week religiously. And the moment it turns slightly green, I ask them to come back to the clinic and do the formal UPC. And in patients who you're tapering the TAC, proteinuria appears, it's time to move to Ritux. But if you're lucky, what I typically do is continue the treatment over about 9 months to 12 months total and then stop, as long as they're in remission during this period of time.
That's wonderful. There's also questions about rituximab being lost. We've talked about, it's bound to protein. You have heavy proteinuria. You're losing some amount of rituximab. And you can have treatment failure. So how are you managing these patients, and what are you doing?
No, it's a great question. So it turns out in minimal change disease, you can see a single dose of rituximab, 375 per milligram per meter squared, is adequate in a whole bunch of patients, right? So you don't need a lot of B cell depletion like you do with, say, lupus or ANCA or those kind of things. So somehow the relative drop, if you will, changes probably B cell function in a way that it sort of changes the biology. So you don't really need deep depletion like you do with other glomerular diseases. 1 or 2 doses of, I usually give a gram times 2 and then just wait for the trap. I do follow CD20 levels in patients who relapse frequently, and if I find that in such patients CD20 is dropping, I know the relapse is coming, so I immediately top up with an add-on dose of rituximab. But other patients, you give 2 doses and just see how things play out.
Do you ever give anticoagulation to these patients?
Oh yeah, so this is not a zero anticoagulation risk, and the lower the albumin, the higher the chance of clots, right? So I generally use 2 grams of serum albumin as being the cutoff to start. I use a DOAC, full doses nowadays, unless there's a contraindication. But yes, all these patients, in my mind, at least should be unless there's a contraindication, should be on anticoagulation, depending on the level of serum albumin.
Sounds good. And one question is really about the duration of rituximab. Like how long are you doing this rituximab therapy?
So it depends on how fierce the disease is. So I've had patients who, if you're steroid dependent, I usually go for 1.5 years straight, okay? If you have frequent relapses, I go for 6 months. So I give 2 doses, gram each, and another dose at 6 months and just wait, okay? And then if they keep coming back with relapses, I go longer and longer with maintenance rituximab. So I've gone as long as 3 years in the most difficult patient. But most times, 2 baseline, gram each, 1 at 6 months, and then see what happens. And I think the point is that patients will relapse even on this. It's not a lifelong sort of switch that goes off. And the best way to monitor them is to just look at home proteinuria dipstick, and then you bring them in very early so when these patients come back with a slightly green dipstick and the urine protein is 1 gram, I give them rituximab right then, right? So I completely avoid steroids in that situation. Within 2 weeks, they're back down to 0, UPC. So yeah. I think the point is that this is a relapsing disease. We have to be aware. And in the absence of a biomarker, I think home dipstick is the best way to monitor these patients.
I feel like a lot of people have asked some of the questions that we have in the case, but if you're okay, we'll share a case with you.
Yeah, sure.
And with all our panelists, and maybe hear from others as well as to what they would do. So just bear with me. I'm going to share my screen. So this is case 1. Are you able to see my screen?
No.
No. Okay. Hold on. I think I did not hit share screen. There you go.
We're good now.
You good now? Okay. Perfect. So this is a 35-year-old patient of mine. I've changed some details around to avoid any HIPAA violations, but who has minimal change disease, diagnosed with minimal change disease, comes in with 10 grams of proteinuria, albumin 0.8 at that time, had lots of workup, infectious, serological, other workup, and everything's been normal or negative. And so on admission, his creatinine was 1, and within 3 days rises up to 4.5, right? And I think you've talked about all of this in your talk already, but really the question is, now you have this patient in front of you. Are you doing steroid-free regimen? Are you going with steroid plus another medication? Is that rituximab? What are you doing, and what are the thoughts, and what would people do on this panel?
I can go first. I'm a big fan of rituximab. And in such a patient, they'll get steroids and rituximab. I'll wait a week or 10 days. If I'm not seeing any improvement in the proteinuria, I will start plasma exchange, okay? Because this patient is at high risk of, permanent AKI going to CKD, right?
Yep.
And that's just, of course, I will anticoagulate this patient as well.
Absolutely. Any other thoughts from the panel?
Hey, Coyle. So I'm more of a even more steroid free. I do tacro and rituximab for all minimal change now. So I start them all on tacro, regardless of the creatinine, because we do that in transplant patients. I don't know why we shy away in GNs. So I actually start tacro and then give rituximab 2 weeks after starting tacro, and taper tacro within like 3 months by the rituximab kicks in. So that's my induction regimen. And then, rituximab every 6 months for 18 months. The only thing is I would echo what Dr. Radhakrishnan does is at least I've picked up now 3 thymomas in resistant minimal change. So it's very important to look for thymomas. I don't think it's uncommon. I think we're just not looking for it. That's 2. And then, the rest will be sort of like the pheresis part. I am more aggressive with multimodal therapy when patients don't respond. So I actually put them on tacro, CellCept, rituximab, and pherese, just like how we do post-transplant when they have FSGS. So why not do the same thing pre? It's like sort of all at once. But that's sort of my approach. It's not what's evidence-based, but it's more of a multimodality like lupus.
Sounds good. And I think, Dr. Raja, you were going to say something as well.
No, my comment, it's a more of a comment and a question. So, I would be using pulse corticosteroids in this patient because you would be able to quickly get down the creatine and maybe allow, things to chip in, other agents like rituximab to chip in. That's what we do because these patients are often bloated and they would also have the gut edema. So you really don't know how much of corticosteroids that you give orally would be absorbed. So, what I do in these kind of situations, give 3 days of pulse methylprednisolone 250 milligrams. And then, most of the times, the creatinine is normal by a week to 10 days. And then, you can obviously use the other regimens.
So that's a great point. Okay.
I would ask the opinion of the house.
So mostly because in the KDIGO guideline that glucocorticoid is usually the first choice, and we use steroid as a initial therapy, and then if there is a poor responder, so we usually don't nowadays wait for 12 or 16 week and start the second agent, mostly CNI till now. Maybe in future more and more people will start using rituximab good therapy. But is the usual trend is there that you start 2 agents together when we are starting the treatment? That is the usual consensus, rather than starting and with glucocorticoids and later on introducing a second agent. That's what I.
So at least for us, I know sounds like Kinar and Jay do this. I do the same. I actually do two agents as well. Usually start off with rituximab. We've seen really great success with rituximab, and especially if the creatinine's high, my preference is Ritux over CNI. But then as the creatinine comes down, I might add a CNI if needed. Often do steroids in Ritux or a low dose of steroids with rituximab. And so I have really, in the past so many years, not done steroids alone in most of my patients, I would say. So to move on with this patient, what happened was this patient came to me and was already on steroids, had not used rituximab. I wasn't the one who had seen them, came to me with this history. I saw them when they were on steroids, tried to taper off the steroids and added rituximab as the preferred second agent for this patient. But before we could add rituximab, there's a lot of social history where he couldn't make it in for the infusions, couldn't get admitted, was a truck driver and was driving across the US. So just a lot of logistical issues. So as we were trying to also taper off the steroids, he kept flaring. And so really ended up needing rituximab. And this goes back to what Dr. Radhakrishnan was talking about, where these patients keep like flaring over and over again. So maybe Dr. Bakchi, if you tell us, we talked about, sorry, go ahead.
Yeah, I prefer using rituximab as first line in steroid-dependent patients. I don't think using combination therapy is still very is widely adopted in India currently. I mean, I think every one of us would be using steroids, and I agree with Raja. I would give pulse steroids in the first phase and then oral. But for dependent patients, rituximab would be first line, I think, because one of the reasons is, of course, it works very well. And I would do, as Dr. Radhakrishnan said, we would give it and then maybe redose at 6 months to 1 year, and we have usually got away with requiring a redose maybe once in 12 to 18 months. And the thing is, it also improves the compliance because these patients are usually very young, even in young adults or adolescents. So they do better with rituximab than daily dosing with CNIs or MMF. And it's also cost effective in India because it's generic rituximab. If you look at the cumulative cost for a year and compare it with MMF or CNI therapy, especially with the drug monitoring, it turns to be more cost effective.
So what about the cyclophosphamide? No, because this is a cost effective we talk about, and we give a 3 months of treatment, and then it's a sustained remission is good with it, cyclophosphamide. So
so pre-retux cyclophosphamide used to be my treatment of choice. I would still give it in some situations where the patient, but most of these patients are young, so I try to avoid cyclophosphamide nowadays, especially with the data coming in for dependent nephrotic syndrome.
What are
But
people's thoughts on obinutuzumab?
So I am at a public hospital, and obinutuzumab is frightfully expensive, so we don't use it. I know my pediatric colleagues have used it. The dosing is less in that, so it's more cost effective for them. But to be honest, I have also not seen a minimal chain disease which we could not manage with rituximab or CNI, so we have not really found the need to use it for steroid dependent.
I've used it in 2 occasions. One is patients on 2 to 3 drugs to keep them in remission.
Yes,
and including rituximab and dramatic response to obinutuzumab. So this is the patient I would do deep B cell depletion. I have only one patient in that setting, and the others who have got allergic reactions to rituximab. And again, they did very well on rituximab. There's no need to change therapies as long as the drug is available and affordable.
Surprisingly, have you all noticed more reactions to obinutuzumab as well recently? We've recently had a series of patients having reactions to OB, which I hadn't seen previously in the past few months, and such that they've been actually needing admission to the hospital at a lower rate of OB to be given to them. Again, this has suddenly happened like a series of patients. I don't know if the drug has changed, the formulation has changed, or is it just that we're seeing it now and it's a fluke?
There's no difference in reactions to OB versus Ritux. It's an equally effective or dangerous drug. Depending, I've had a lot of weird reactions like precipitation of Crohn's, a skin reaction, neutropenia, thrombocytopenia. All these are known with both drugs, and there's no difference.
I think someone mentioned that in the chat as well of Crohn's from rituximab.
And I just keep going. Treat the Crohn's with the biological. Keep going with the B cell.
I have a comment here. So some patients who are very steroid sensitive, and we're talking about if they relapse, they get 20 milligram of pred for a week and they go in complete remission. Maybe they're relapsing once every 3 years. So I have a bunch of patients like that I'm able to give them this, burst of 20 of pred for a week every 3-5 years. So would you suggest treating these patients with rituximab or keeping them on maintenance like that for long term? And this is a question for the panelists, so anybody could chime in here.
Yes, this must be one of these childhood type of nephrosis. But again, the biology has not gone away, right? So if you're looking at 3 to 4 relapses a year, even if it's a short relapse, I would say
no, it's relapses once every 3 to 5 years.
Oh, then it's okay. And if they respond in 2 weeks, but the question is, how long will you keep them on prednisone? Right? So if most of us would not stop the prednisone in a week. I mean, that's so your cases are unusual because in adults, especially, it takes a little longer to go into remission, and if we stop too early, they go into relapse. So I don't know, but these patients are very unique. They may be having one of these so-called URI flares, which Dr. Bhakti, you know this much better than all of us, right? Which sometimes can be treated with a very abbreviated course of prednisone.
So what I often do is I tell these patients that whenever they have infections, they do the dipstick at home, and surprisingly, they always turn positive. And sometimes what happens is once the infection resolves, even before you start steroids, the proteinuria disappears. And if it doesn't, if it's sustained for 2 to 3 days, then I ask them to start on low dose of steroids. And then we taper it off very fast. And this does happen. I mean, we have, it has become less after we have started regular vaccinations, influenza and all, because that was not very common in adult patients in the past. So we have seen better results and a reduction in relapses with the regular vaccinations, but this is something I do tell the patients.
And then I
Yes.
think Dr. Raja has a
Yeah,
comment.
I have a question rather than comment to Professor Jay. This is regarding antinephrin antibody is an, MCD is an autoimmune disease now. But once you give steroids, the patients sometimes respond even in a week. Like if you take the kids, like the antibodies are yet in circulation. Like how do these patients respond within a week? That is something I
Yeah,
faced.
so that's been the whole one of the controversies. Are these just biomarkers of association, or actually are they causative? So one reason maybe is that many of our drugs affect the porocyte directly, right? CNIs and even
Yeah.
steroids, right? So you may have this discordance where the antibodies are there, but the porocyte is being directly affected with the medications, and so so you go into remission much quicker than the antibodies going away, unlike membranous, right? So that is the hand waving, explanation. So unless we are 100% sure with larger trials that the antibody is causative, right, not just association, we will continue to sort of at least do our best to with the premise that the antibody is somehow related, but we will
Yeah.
keep treating them in the same manner.
And then it seems like I planted Dr. Raja and the panelists, because my question was about how are you going to use anti-nephrin antibodies? And I know that you divided and you told us, but I think it's not available. When do we anticipate it'll be available? Would it be available to everybody? Testing, like what do you think is going to be the future with this?
You want
Dr.
me?
Raja
Yes, so,
or Kinar, please go ahead.
because I've used it, with I send it to Astrid, but you have to do it right before the any treatment, especially steroids, because it quickly drops within a couple of days of giving immunosuppression. So if you started treating the patient already, you're going to have a negative antinephrin. Correct me if I'm wrong, Dr. Radhakrishnan, but that's usually what what we have seen. And it actually, if you freeze them, it goes away. If you actually follow up the levels post treatment, it goes down. What I would suggest is you don't even need the levels. If you have a very good pathologist and you can actually see the IgG dusting on the IF, if you biopsy these patients, pediatric maybe not, but actually that's what we've been using. I tell the pathologist to look for the dusting on IgG, and that classically is antinephrin. That's what Helmut Ranke described many years ago. He would call these sort of dusting like phenomenon. So I think if you follow that, you don't even need the levels, at least from a PAT standpoint. Well, I don't know, Jay, if you had any other thoughts.
No, I think it's the whole story is still in development, but
Yeah.
we have such effective drugs. I think that's a good news, right? So whether or not the antibody holds out, but I think especially with Rituxan, all these other drugs that are available, this is a highly treatable disease. The question is, we don't want to damage patients with treatment. So it would be nice to have a biomarker to sort of tell us how long, what agents, and so on. But still, with minimum damage, we can manage these patients quite effectively.
And I think we have a last comment by Dr. Raja.
Yeah. We tested for the antinephrin antibodies by an in-house panel, but it was only 23% for IgGs and IgM was about 10%. And the positive control for this we used was antinephrin antibodies. Surprisingly, what we found was in FSGS patient, we have a biorepository for the last 10 years. So what we found was in post-transplant FSGS, 3 out of the 4 patients are actually antinephrin positive.
Yeah.
Compared to vis-a-vis, these standard MCD cases, and all of them, we also have the follow-up samples. All of them, are negative on the follow-up, which is about 3 to 6 months, where we looked at T and B cells. For that, we collected those samples. They were all negative. So looks like, it's a reasonable marker for disease activity, more so for recurrent FSGS. Yeah.
Thank you. And
I
I
just
think
want to just answer one question in the chat about TB, right? So I think it's very important before any immunosuppression to do a quantiferon gold or even if it's in India, although the prevalence is high, we have to put them on therapy, and a lot of times there's a lot of the thought that it's everyone has it, so they shouldn't be treated is, I think, patently wrong. You should look for it, treat them with the with the chemo prophylaxis before hitting them hard with immunosuppression.
and just on the same lines, checking hepatitis B, C,
Yeah.
especially core antibody for B, so doing all of that as well. Dr. Radhakrishnan, thank you so much for that amazing talk. If you don't mind sticking around for just a few minutes and responding to some of the questions in the chat, and then we will go ahead with our next by Dr. Arora.
So I'd like
Dr.
to introduce
Jayapuri, I
Dr.
will let you.
Arora, Swati Arora. She is our speaker for the next topic, which leads right into it, FSGS. She is from Pittsburgh, and she's an associate professor of medicine at the Drexel School of Medicine, has been participating in a lot of GN trials and GN registry. Without further ado, Swati, take it over.
Sure, thank you. I'm just going to quickly share my screen here. Just a second. It's not coming up as a... Does it come as a full screen or not yet?
Not yet.
Okay. Is it better? Perfect. Okay. All right. So thank you so much for having me here today. I'm going to be talking about FSGS. The good thing is that Dr. Radhakrishnan covered a large part of my talk, so it will be much shorter. So we're going to talk about the burden, the classification of FSGS, diagnostic dilemmas, then we'll go into treatment challenges. So FSGS is the commonest cause of nephrotic syndrome in the US, 5 times higher incidence in Black versus white patients, and 40 to 60% of patients progress to end-stage kidney disease within 10 to 20 years from diagnosis. And we know there's a strong association of FSGS with the apolipoprotein L1, ApoL1 gene variants, which is more common in patients with African ancestry, and they're exceedingly
Swati,
rare in
sorry
India.
to interrupt. Is everybody just seeing a blank screen, or can you
We
see
can't see we can't see the presenter mode.
Oh, really?
It says your screen sharing is paused. That's what it says. So you just unpause it. Yeah, now we can see. Now just do slideshow mode.
Is it good?
It's
Yeah.
not. Oh, yeah, that's perfect. Thank you.
Awesome. Thank you for pointing that out. Yeah. So I was talking about ApoL1 variants being exceedingly rare in India, South Asia, or East Asia. So looking at the spectrum of primary glomerulopathies in central India, so this is, as you can see here, FSGS is the third most common cause of primary glomerulopathies in central India. So let's talk about the burden. So this was a cohort of about 228 patients. These patients had mean proteinuria of about 7 grams, mean creatinine was around 2.8. So these were a pretty sick population. And as you can see, the complete remission rates were about 12%. Partial remission rates were 43%, with high rates of relapses up to 63 to 75%. And then 39% of patients reach end-stage kidney disease with a median follow-up of 4 years. The risk for end-stage kidney disease were if patients were non-responders. So as we know, even if you start a therapy and even if you have a partial response, those patients do better in the long run as compared to patients who do not respond. If the baseline GFR was less than 30, then obviously we're late in the game, right? We're catching them late. They already have a lot of scar tissue, so the risk of ESKD is higher. And if the patients were Asian or Pacific Islanders ethnicity, and the mortality was up to 27%. So this kind of highlights that we need better, newer targeted therapies for managing these patients and for preventing end-stage kidney disease in the long run. So going over the classification of FSGS, now this is really important because that's what dictates the underlying etiology and the treatment. So I want to first go over on the right-hand side. So this was the Columbia classification that came in early 2000s. And it kind of divides FSGS lesions in 5 different varieties. And it does help somewhat with, the prognosis. So as in, if you have a tip variant, then these people were very steroid responsive. If you have a collapsing variant, these people had very bad prognosis. But then it did not tell us anything about the underlying etiology or pathophysiology. So that's when KDIGO 2021 moved towards classification of FSGS based on what do we think is going on underneath, right? So they said, is it primary or immunological FSGS, which is related to circulating soluble factors? And Dr. Radhakrishnan went over anti-nephrin antibodies already. So we know that this does target the antibodies in the slit diaphragm and it causes primary FSGS. And these are the kind of patients who are most amenable to immunosuppression. Then is it genetic FSGS? So I'll talk about that in a minute. Or is it secondary FSGS, which could be from maladaptive changes? So you can have somebody who has reduced nephron mass from birth. Maybe they were small for gestational age when they were born, or they had reflux nephropathy, or they have a lot of burden on them, meaning they have uncontrolled hypertension or obesity, which causes maladaptive changes and hence secondary FSGS. Then drugs, maybe like lithium, anabolic steroids, or bisphosphonates can cause it. And then lots of viral infections out there like HIV, CMV, EBV, and even COVID-19. And also some parasitic infections like Plasmodium or filariasis can lead to secondary FSGS. Now, if you have a lesion of FSGS on the biopsy and they did not fit these 3 categories, then we're talking about FSGS with undetermined cause. So this slide I'm actually thinking to skip because we just went over the slide with Dr. Radhakrishnan. Okay. So the diagnostic dilemma. So here is where the problem is that we have to come up with, okay, in which category are we going to fit our patient? So the thing that helps us the most is actually the clinical scenario. So if you have a typical patient who comes in with full-fledged nephrotic syndrome and you ask them, okay, so when was the last time you remember you were just fine? And then sometimes they would say, I remember before Thanksgiving I was fine, but right after that, my feet started swelling up and I gained 15 to 20 pounds of weight gain. So that's when you kind of think about, okay, am I dealing with primary FSGS here? And then on electron microscopy, if you see diffuse foot process effacement, it kind of supports it. But I also want to mention that we don't want to be fooled by just the presence of diffuse foot process effacement as equivalent to primary FSGS, because it could be present in other cases such as genetic FSGS as well. And then the light microscopy really doesn't help. Traditionally, we were taught that if patients have enlarged glomerulomegaly, then think about adaptive FSGS. However, 10 to 30% of patients with presumed primary FSGS also have glomerulomegaly. Then adaptive FSGS patients usually have either subnephrotic proteinuria or nephrotic range proteinuria. So they could easily have 4 to 5 grams of proteinuria. But the key is their serum albumin is well preserved. And that's why they do not qualify the classic definition of nephrotic syndrome. And usually they have gradual progression going over maybe months to years. And in these patients, usually we find focal or segmental areas of foot process effacement on electron microscopy. Then genetic FSGS is kind of all over the place. So usually nephrotic syndrome is more common in childhood, but less common in adults. And then the foot process effacement could be variable. It could be diffuse or segmental foot process effacement. And then if your patients are not falling in any of these categories, so they have variable proteinuria, no evidence of secondary cause, yet their genetic testing is negative, and they have minimal or no foot process effacement and unaffected glomeruli, then they're classified as FSGS of undetermined cause. And I also wanted to mention this is extremely important, not from the standpoint of only from the treatment standpoint, but also if these people reach end-stage kidney disease and need a transplant, then the risk of recurrence is pretty high in primary FSGS and low in other classes of FSGS. And this is from KDIGO 2021 recommendations. So if a patient has FSGS lesion on kidney biopsy, so it's a lesion, right? We're not saying they have a disease, they have a lesion. Then the next question is, does my patient has nephrotic syndrome? If the answer is yes, and especially if they have diffuse foot process effacement, then we pull the trigger for, okay, we're dealing with primary FSGS most likely, and then we treat them with immunosuppressants. And if there's no response, we consider genetic testing. However, if they don't have nephrotic syndrome, and we already went over this already, then we evaluate for secondary forms of FSGS, we consider genetic screening, and we do not start immunosuppression, but maximize their supportive therapy, which I will be going over in a few minutes. And if they have worsening of the proteinuria or decline in serum albumin, then we go towards the left side of the chart. And then the question is then, whom should we offer genetic testing in adult onset FSGS? So we have already talked about the left side of the slide, that if we think they have primary FSGS, they're resistant, then consider it. The right side of the slide is pretty easy as well, that you have secondary causes. They do not have nephrotic syndrome. They have segmental foot process effacement, then most likely it is secondary FSGS, and we can leave it there. But then the middle two boxes are about the gray zone. So as an example, there's someone with no nephrotic syndrome clinically, but on the biopsy on electron microscopy, they have diffuse foot process effacement. So because it is not fitting right, so you would want to consider genetic testing. Similarly, a patient, whether they have nephrotic syndrome or no nephrotic syndrome, they have segmental foot process effacement, but you've ruled out other secondary causes, then we should consider genetic testing. And this is list of the genes. It's not the complete list. Honestly, they're discovering new monogenic genes that are related to FSGS. But these are the genes that have to deal with the cell matrix, slit diaphragm, cell signaling, and such. And I'll talk about precision medicine in FSGS at the end of the talk. Okay, so the supportive therapies, the ones we're very familiar with, are RAS inhibition, diuretics, low sodium diet, and statins. So I want to spend a little bit more time on SGLT2 inhibitors and endothelin receptor antagonist here. So this is from the subgroup analysis of DAPA-CKD study. And in their cohort, they had about 104 patients with biopsy-confirmed FSGS. Mean age was 54, mean GFR 42, and albuminuria of 1.2 gram per gram. And they looked at the patient's DAPA arm versus placebo. So within the first 2 weeks, the decline in proteinuria was about 26% in the DAPA arm versus 9.9% in the placebo arm. And as we know with SGLT2 inhibitors, we anticipate acute decline in GFR, which was a drop by about 4.5 ml per minute per year in DAPA arm versus minus 0.9 in placebo arm. However, the chronic slope showed that the patients in the DAPA arm had an advantage of about 2 ml per minute per year of GFR. However, this was not statistically significant. Also, the numbers were pretty small. And then looking at the duplex trial, which looked at sparsentan, which is a dual endothelin angiotensin receptor antagonist. So it inhibits both your ETA and the angiotensin 2 receptor versus irbesartan, which only inhibits angiotensin 2 receptor. So they looked at about the patients with primary FSGS in the age group 8 to 75 years. And they randomized the patients in the sparsentan arm versus irbesartan. And what they found that at 36 weeks, the rates of partial remission were higher, 42% in the sparsentan arm versus 26% in the irbesartan arm. And this was statistically significant. However, there was no difference in the GFR slope over a follow-up of about 2 years, and the adverse events were pretty comparable. So with this, sparsentan received FDA approval in April of 2026 for FSGS without nephrotic syndrome. And the reason they said without nephrotic syndrome, because when they did the subgroup analysis in patients who had nephrotic syndrome, there was no difference between the two arms. And then just a little bit on the non-steroidal mineralocorticoid receptor antagonists like finerenone, which has anti-inflammatory and anti-fibrotic properties. So this was studied in obesity-related glomerulopathy, which showed significant reduction in proteinuria and stabilization of GFR. Now we're going to go towards the more challenging part of FSGS, which are the immunologic therapies for FSGS. And so this part was, again, covered by Dr. Radhakrishnan, because the management of minimal change disease at the start or in the patients who are frequently relapsing or steroid dependent, in patients with primary FSGS is very similar to minimal change disease. So I'm not going to go over this again. And we have already seen this slide as well. And this was on, okay, so if you have adults who have frequent relapsing or steroid-dependent nephrotic syndrome, then we saw that rituximab did improve relapse-free rates by 87% versus 38% in placebo. So then the question is, what do we do when you have resistant FSGS? So steroid resistance is a significant problem in FSGS, which is encountered in 40 to 60% of patients. So KDIGO 2021 suggests calcineurin inhibitors as next line of treatment. If the patients are intolerant to calcineurin inhibitors, then they said that you could possibly consider mycophenolate or rituximab or ACTH, but we don't have enough evidence, so preferably send the patients to a specialized center for further alternative treatments. So I want to point out that this is only in the cases who are intolerant to CNIs, but KDIGO 2021 does not suggest mycophenolate in CNI-resistant patients, and this was a change from KDIGO 2012 and 2021. And then International Pediatric Nephrology Association does recommend rituximab as a rescue therapy in steroid-resistant and CNI-resistant nephrotic syndrome. And this is, so this we have not seen in the prior lectures, so I'm going to go over this. Okay, so the question was, if we add rituximab on top of other immunosuppressants in patients with primary FSGS, then what could be the outcomes, right? So the population they had, about 160 patients, 90 patients were steroid resistant and 70 patients were steroid dependent. Mean age was 25. Mean serum creatinine was 1.5. And what they saw that the response rate was 57% at 3 months. That got better to about 74% by 12 months. And then the response to rituximab was positively associated if patients had lower baseline proteinuria, which in the study was less than 5 grams per day. And if they were steroid dependent, they had more positive responses. And if they saw the FSGS non-otherwise specified NOS variant on the biopsy. And the response to rituximab was negatively associated if they had CNI resistance or if the CD20 was repopulating. And the sustained remission rates were 69%, and relapse-free survival was 83%. So it did show promising results in patients with primary FSGS, including the steroid-resistant patients as well. And this slide we already went over with Dr. Radhakrishnan, so I'm not gonna go over this again. Okay, and this is an update from ERA Immunonephrology Working Group. And as you can see, these are the recommendations from KDIGO 2021 in the middle. And then based on the recent developments, this is their proposal. So initial treatment about the same. So they're saying oral steroids. If contraindications, you can go to CNIs. If you have relapsing or steroid-dependent disease, then you could consider calcineurin inhibitor. And this rituximab, which was kind of questionable on the KDIGO 2021 guidelines, was proposed to be higher in our choice of drugs or the sequence of therapies. And then if you have steroid-resistant disease, then we already talked about KDIGO 2021 recommends CNIs, but this working group is proposing you can use either calcineurin inhibitor or rituximab. So I know there were some questions in the chat about obinutuzumab in multi-drug resistant FSGS. So far there are case reports, and then there was one open label trial with 20 patients. This is actually, it was presented as a poster. I did not see the publication for this, but I still thought it's worth mentioning. So 40% of these patients achieved complete or partial remission. Then there was another case series in 11 patients with minimal change disease or FSDS, in which 6 patients were able to get rid of the steroids within 3 months of obinutuzumab. And then there is some data out there on use of anti-CD38 along with anti-CD20, but mostly in the post-transplant FSDS. And then extracorporeal therapies like your plasma exchange, immunoadsorption, LDL apheresis could be used as an adjunctive therapy if patients are having a very resistant disease. So moving on to the precision gene therapy. So we know that 20% of individuals with steroid-resistant disease have monogenic etiologies. I know it's a very busy slide, but I just wanted to just give you a flavor of like we have now inaxaplin, which is an oral inhibitor of ApoL1, and in a phase 2A study, it did show 47% reduction in proteinuria. And then there are ongoing trials with ApoL1 inhibition as well. And then recently they published this TRPC6 inhibitor, which showed reduction in proteinuria and was well tolerated. And if patients have this transmembrane ABCA1, which deals with the cholesterol efflux from the podocytes, they're starting the small molecule R3R01. It's an ongoing phase 2 study. And then if patients have genetic mutations with coenzyme Q10 biosynthesis, then the replacement with CoQ10 supplement can lead to clinical improvement. So that's very exciting. And then they have other trials, which I'm not going to go in depth right now because of for sake of time, but a lot is in the pipeline, and these are very exciting times for FSGS. And this is from an editorial. I love this picture that at present we're thinking about steroids and CNIs, maybe mycophenolate. In near future, which is I think at present, I should say more or less, we're moving towards rituximab. And maybe in future, we're thinking about obinutuzumab or daratumumab and more. So this is a little slide on my take-home message that anybody with FSGS, you want to do the supportive therapy, and I added sparsentan here. For primary FSGS, steroids, CNIs, or rituximab. For secondary FSGS, treat the underlying disease. Genetic FSGS, we kind of had a little sneak peek on precision medicine. And for undetermined cause, we have to monitor and maybe repeat the biopsy. And this is it. Thank you so much.
Thank you, Swati. Thank you. We're going to have some questions from the chat. I can read some of them. I think there's a generic question to probably both Swati and Jay or the panelists, the use of SGLT2 inhibitors in patients with podocytopathies.
Yeah, I personally don't use it just because the data are soft and you're adding another pill with unclear benefits, right, in this patient. Of course, when they hit CKD, when GFR drops, then that's the time in any patient. But if you have a completely normal GFR, maybe a little wasteful, I think.
So in DAPA-CKD, they excluded patients on immunosuppressants. If you're treating these patients with heavy immunosuppression upfront, I don't think it's the best time to introduce SGLT2 inhibitors. However, once we are, tapering them off and then, or especially we're dealing with, let's say, cases with secondary FSGS and such, then I definitely add them on.
Yeah. Also, just to be clear, I'm just talking about the primaries, right? So-called. I mean, every secondary should be on it, right? No question.
Shyam?
Yeah.
Sorry, I don't know what happened.
No, that's fine. So great talk, Swati. So again, if you see the most of the guidelines, they would use the rituximab or CNI as a second line agent. Am I audible?
Yes.
Yeah. As a not to start with. So what they mean is our practice has always been to start the steroid and then see if there is a poor response or the steroid dependent or the steroid resistant or frequent relapser, then we give rituximab or some other therapy. So So that's a shift on, because the guideline also, if you see the KDIGO guideline or even the ERA, so this is not the first line drug, rituximab. Is it being used as a first line drug? I mean, what is your practice in FSGS?
Not as a first line, I would say. Yeah, I don't use it as first line. I always start, if it's primary and okay, so there are flavors of primary, right? So if you've got nephrotic syndrome, slightly low albumin, I always start with the CNI, see how it does. But if it's a patient with a very low albumin who's got, AKI, just like the patient that we presented in the who's minimal change, in that patient I'm going to use first line rituximab. So it all depends on how much you think the patient has got a immune basis, right? So, and I think Swati nicely laid it out. The lower the albumin, the more nephrotic they are, the more acute the onset is. And they lean towards the immunological profile. And in those patients, I use first line B-cell therapies, but usually with tacrolimus. It's combined.
Okay. And what is we usually use this plasma exchange and all that in post-transplant recurrence, but we have hardly used them as a treatment in the patient with the FSGS in native kidneys. So what is your experience of remission in those patients with the steroid resistant or the CNI resistant? Is it again means you start it early if you see the patient is steroid resistant, or you wait for some time? Because plasma exchange we have not very commonly used in our practice, at least in native FSGS.
Hey,
Yeah.
Cannot.
I mean, to me, I think I've learned a lot from post-transplant FSGS. And again, like Jay said, it's a different flavor. Certain patients, I actually do upfront multimodal, like I said. Like right now, I feel like the net immunosuppression is less when you give them multimodal upfront than sequential therapy. So that's just, one way of thinking about it, rather than, so I do actually upfront Faris first, then, give them calcineurin with rituxan. So rather than just like a transplant patient, because they do go into remission when you give them CellCept, Tacro, Rituxan, and pheresis all together. But those are like you can know that patient right away. They're severe nephrotic. They come in with a PE or DVT. It's not your very mild nephrotic syndrome in a way. It's the one you will know right away. Like the collapsing variant, I would treat more aggressively with that approach. But again, that's a post-transplant approach used pre-transplant, but that's not what the guidelines say. The guidelines will still say sequential therapy. You try one first, then put the next, then do the other. Many people are not using combined therapy, which I think should be the future of FSGS.
And to be honest, we do the same. Like I have moved more towards or more away from steroids, or the amount of steroids that are used, and like all the guidelines are 16 weeks of 1 mg per kg up to, the guidelines tell you to use a lot of steroids. And I think they're just guidelines, right? Like they help you, but I think you need to make an informed decision. So what I've tried to do is, even if I, let's say, use steroids, I've realized most patients don't respond to steroids alone for FSGS, at least in my population. So I've started using CNIs more upfront and then adding rituximab. And so using that more, I will say for plasma exchange, to answer that question, I haven't used plasma exchange right off the bat. We do have an LDL apheresis trial here at UNC, and I'm the PI for that. So we will do LDL apheresis, but typically more towards like the resistant, not responding to other things. But that also has like EGFR cutoffs. You can't just use it for an EGFR really low. And so caveats with that.
Looks like
No, I
people in
want to
the
point
chat are
out.
putting stuff there too. So Swati, go ahead.
Yeah, I want to point out that I think the recurrent FSGS in a transplant is kind of you're walking with the natural history of the disease. You're catching it within like hours or weeks as soon as the patient has the recurrence. There's yet not enough time for the lesions to become focally sclerotic or anything, right? So that's why the results with plasmapheresis and this multi-targeted therapy works best. But in our, I would say, primary FSGS patients, usually we're late in the game, and the way the trials have been done, the patients who were included are kind of all over the place. We don't even know if they were truly primary FSGS, so very heterogeneous population. So that's why there's a variation between recurrent versus primary FSGS with respect to plasmapheresis.
So, I mean, similar, I think people are putting their experience in the chat, so I think people can read that. One of the other generic questions people have been asking is about genetic testing upfront for both primary and secondary FSGS. What do you think about that, Swati?
I don't offer it upfront if the patient is truly presenting as a primary FSGS. The presentation on my history taking, if I feel it's an acute onset and, falling in lines with primary FSGS, then I do not offer upfront. However, with everybody else, a lot of times, if I'm not really sure that it is truly secondary FSGS or not, so my threshold for ordering genetic testing is much lower now, and I'm doing a lot more as compared to before.
And the last question I just wanted to put in is just I always wondered if collapsing FSGS is a podocyte malignancy. I know podocytes are completely differentiated, so they won't become a cancer. But when they de-differentiate, they proliferate. So are we missing a podocyte cancer when it's in collapsing FSGS? I don't know. I'm just putting it because from the onconephrology hat. Jay, Swati, any thoughts?
No, I think it's just a de-differentiation. And the problem is that whatever injury causes the podocytes to differentiate. I can't remember if there's any other, analogy in other cell types, right? But
yeah,
this is unique. So I think the one thing that really messes up podocytes is interferon, right? And I think that's the strongest. And the pathways have been kind of they've figured out the pathways for this, and they're quite unique to interferon. So I think interferon is the biggest risk for podocyte de-differentiation. And if the interferon signal passes, then they revert to the scarring type over time.
I wonder though, right? Like, it's like the chicken or the egg, right? What came first? I wonder if there is like whatever the trigger for injury, whether it's interferon or something else, causes the collapse first. And now you have podocytes that are getting de-differentiated and then just sort of filling up the space that is left behind, versus is it actually the podocytes proliferating and then causing the collapse? I don't know, we know which came first when we see collapsing. And so I wouldn't go as far as calling it cancer. But yes, the differentiation and proliferation is happening. I do have a question for the panelists. I just want to go back to the genetic thing for just a second. Maybe Dr. Bagchi and Dr. Ramchandran and Dr. Bansal can weigh in for India. I tend to do a lot more genetic testing. I feel like I used to do less, and I've realized that even with primary FSGS, I'm seeing a lot of overlap, and like especially the call4 mutations. You could still have primary FSGS in presentations, or you could have secondary, and we've got a lot of mutations. So what are you all doing with genetic testing? Is it easy to get? Is it something that you're doing routinely?
Yeah.
Go ahead, please. Go ahead, Shamita.
Yeah, so genetic testing has really become much more affordable in India in the last few years, and with a lot of commercial laboratories offering them. And so what we tend to do in our practice is, if a patient doesn't respond to steroids, personally, I feel that we should go ahead and do the genetic testing. Because even with CNI, genetic FSGS, some forms do respond to CNI. So it is better to have that baseline, especially with the lower costs. But what I also wanted to highlight is that before escalating immunosuppression in a patient who is not responding to steroids, it's very important to rule out the genetic and secondary forms of FSGS. So we need to be a little bit more detailed in our history taking and investigations for that. And the other thing I wanted to get back on was your question on SGLT2 inhibitors. I think it's being overused, especially in GNs, because most of the data, whether it's for IgA or FSGS or membranous, they were not meant for studies in these glomerular diseases. And I think we are using it much more. I mean, in every GN patient ends up getting SGLT2 inhibitors as if it's an equivalent of an AC inhibitor. So I think we should tend to avoid that. Personally, I would use immunosuppression with ACE inhibitors. And if the patient is chronic or if is in a partial remission with a proteinuria of around 1 gram, then maybe yes, SGLT2 inhibitors, because first thing, it adds to a cost, and second thing is, in hot climates, prolonged SGLT2 inhibitors, the patient goes into remission, comes for a long follow-up after a long time. There is an attendant AKI risk. So it should not be universally used the way we use ACE inhibitors. It is not a RAS blockade, put it that way.
I think in the interest of time, a really good discussion, but I'll have Sham move on to our next speaker. Thank you, everybody.
I'm going to be leaving, so thank you very much for the invitation.
Thanks, Jay.
Okay, bye-bye.
Thank you.
Thank you. Bye.
Are we going to take a break for 5 minutes?
I think we can move on, just so that we can have more time for discussion here.
So our next speaker is Dr. Raja Ramchandran. Dr. Raja Ramchandran is a additional professor of nephrology in prestigious PGI Chandigarh, and he has done a lot of work in membranous nephropathy and other glomerular diseases, and his keen interest in the glomerular diseases and also in the complement-mediated diseases. He has been involved in multiple trials. So I would invite Dr. Raja to deliver his talk.
Thank you, Dr. Bansal. Am I audible?
Yes.
Yeah.
Yes.
Yeah. Thank you. Thank you. Thank you again, ISN and NIO. Membranous nephropathy is the most common glomerular disease, most common primarily glomerular disease in the middle-aged. And the outline for my lecture would be is a general introduction, then how we have graduated from just an idiopathic MN to antigen-based MN class stratification, then conventional treatment of membranous nephropathy with cyclical therapy and rituximab, and newer ways of treating membranous patients with rituximab, and what are the recent studies which have evaluated newer therapies in membranous nephropathy, or combination therapies in membranous nephropathy. Membranous nephropathy is governed by a rule of third. That means 1/3 of the patients have spontaneous remission, 1/3 have continue to have nephrotic range proteinuria if they are not treated properly, and 1/3 of them would progress to chronic kidney disease and later on to end-stage kidney disease. Proteinuria somehow remains the only suitable progression marker in patients with membranous nephropathy. What happens to patients who have subnephrotic range proteinuria or non-nephrotic range proteinuria? So if you take 100 patients of patients with non-nephrotic range proteinuria, a very nice study from the Toronto GN registry, 40% of them would not progress to nephrotic range proteinuria itself. And in the 60% who progress, most of them would happen in the first year itself. If you look at the long-term outcome of the patients, those who never progressed to nephrotic syndrome have a GFR drop of less than 1 ml year. Whereas those who progress to nephrotic syndrome, they have about 3.5, and those who have nephrotic syndrome at presentation, they have close to 5 ml per minute drop in the GFR. So the patients with non-nephrotic range proteinuria, very good prognosis. The next aspect is how have we moved in our understanding of membranous nephropathy. So if I had to put, it was initially called idiopathic membranous nephropathy, and we have now moved on to antigen-based classifications. And many of these antigens are also associated with secondary diseases. There are about a dozen antigens, and the Professor Sethi's lab have a custom of updating a new antigen every year. So I think it's close to a dozen now. And the most relevant antigens, at least for the Indian subcontinent, I would say is PLA2R, which is there in about 70 to 75% of the patients with membranous nephropathy. And the second one is the NEL1 associated membranous nephropathy, which is associated with complementary medicines or with use of skin whitening creams. Thrombospondylin, which was actually the third antigen that was reported in membranous nephropathy, somehow not very frequent in Indian population. The other antigen of interest is exhaustocin 1 and 2, which is seen in patients with autoimmune and allergic diseases, most common one being lupus nephritis. Coming to the PLA2R antigen and the significance of the antibodies, PLA2R antigen is a transmembrane protein that it has an intracellular component, transmembrane component, and an extracellular component. In the extracellular, there are about 10 epitopes. The most common epitope to which antibodies are usually formed are is to the cysteine-rich domain. And with the passage of time, in patients who do not respond or patients who do not receive immunosuppressive therapy, what people have gone on to report is there is antigen switching. There is epitope switching to other epitopes as well. Like you could develop antibody to C-type lectin domain 3, 7. And whenever you develop these kind of antibodies to other epitopes, the prognosis is not good. Although there is this statement is debatable with conflicting results from the French and the German group. What is the significance of PLA2R antibody? It can be used for diagnosis of membranous nephropathy in patients with normal kidney functions and your ruled out secondary diseases. The second one, it has a very good association with the clinical activity. You have the antibody showing up first, then development of proteinuria. And once you treat with immunosuppressive therapy, you have the antibody disappearing, and then the clinical remission happening. And it has also changed the way we manage membranous nephropathy. So if you have a patient whose antibody disappears but still continues to have nephrotic range proteinuria at the end of 6 to 9 months, you could wait for these patients for a longer period of time. And also there is a stratification. Patients with an antibody titer of more than 150, their response to conventional therapies is not good, especially rituximab. So coming next is about the Nell-on membranous nephropathy. This is a systematic review that we did along with our Australian colleagues. So what we found in the systematic review in patients who had complementary medications associated membranous nephropathy is close to 90% of them was related to intake of compounds containing mercury, and most of them were indigenous medications, skin whitening creams, or dye. And the vulnerable or predisposed population was those in the fifth decade, female sex, and from the Asian cohort. Most of the reports came from Asia, and close to 95% of these patients had NEL1 associated membranous nephropathy. The best thing was, more than the remission rate was close to 90%, even in patients who had conservative managements, with almost two-thirds of them having complete remission. Yes, some patients did receive immunosuppressive therapy, and the response rate was similar in patients who received immunosuppressive therapies. I think you cannot compare orange and apples, because patients with severe disease would have received immunosuppressive therapies. So what are the secondary, how do you rule out the secondary causes of membranous nephropathy? That what we do in our unit is we rule out connective tissue disorders and hematological diseases by doing an ANA and serum electrophoresis C3, C4 levels. Viral markers, hepatitis B, C, and HIV. We also do the core antibodies, because if the patient turns out to be core antibody positive and HBV DNA is negative, when if they receive immunosuppressive therapy, we give them tenofovir during the period of immunosuppressive therapy. Regarding malignancy screening, although not adequate, what we do is we do HRCT for smokers, chest X-ray for non-smokers, pap smear, mammography, urine examinations for atypical cells, and stool for occult blood. And in patients who have a history of taking complementary medicines or who have segment sensitivity for IgG, what we do is we do mercury level assessment. Coming to the most important part is immunosuppressive treatment. See, stratification of membranous nephropathy has been like, mild, moderate, high risk, and very high risk. In simple words, if they have a non-nephrotic, it's called the mild. If they have proteinuria in the nephrotic range, but not too much, it's the moderate. If they have a lot of proteinuria, more than 8 grams, or have markers of severe nephrotic like albumin of less than 2.5 or very high anti-PLA2R, where the probability of spontaneous remission is low, it is classified as high risk. Very high risk is those with who present with an RPR of like presentation, though rare, or patients who have developed venous thromboembolism. These are the patients with very high risk. The KDIGO recommends conservative therapy for the non-nephrotic patients. Those with moderate, they recommend rituximab or calcineurin inhibitors. And patients with high risk, recommendation is rituximab or cyclical cyclophosphamide and corticosteroids. In patients with very high risk, the KDIGO recommends cyclical and alkylating therapy and corticosteroids. The next is about what is the evidence that for with respect to use of the cyclical therapy. There are at least two trials which looked at the long-term outcomes. One is by Professor Jha and one is from the Ponticelli, where they reported very good outcomes with respect to CKD progression, um, dialysis requirement, and death in patients who received cyclical therapy vis-a-vis those who received only supportive therapy. Based on these two studies, the 2012 KDIGO guidelines recommended, modified Ponticelli as the first-line therapy for management of membranous nephropathy. The problem with the cyclical therapy is, only 20, a survey was being conducted, most of them being Indians, only 25% of them, felt comfortable using this regimen. And, 48%, that is close to 50%, avoided the use of methylprednisolone pulses. The second one is patient non-compliance. If up to 30% of the patients, there would be non-compliance. Most of the times, the non-compliance is because of the acute steroid withdrawal that we do. And many a times, the patients attribute it to the addition of cyclophosphamide. One-fourth of the patients have clear evidence of hypothalamic pituitary axis suppression, although, they are largely asymptomatic. And, there are other, wide range of complications that come with use of this high dose of corticosteroid. Remember, the amount of steroids used in membranous nephropathy is the highest in nephrology, including kidney transplants. So, using this high dose of corticosteroids would come up with its own set of complications. And even the cyclophosphamide, we use about 13.5 grams in the modified Ponticelli protocol for a 60-year-old patient. So this is a review article which was reported in the Kidney International report by Professor Fervenza, where they reported various trials in membranous nephropathy in the last a decade and a half. So one was our study on tacrolimus and modified Ponticelli regimen, then the Gemritex trial, Mentor trial, Recyclo trial, and the Sarman trial. First is, our trial which we did was comparing tacrolimus along with some corticosteroids versus the modified Ponticelli regimen. What we found was at the end of a year, the remission rates in Ponticelli and, tacrolimus and corticosteroid was seen. 3/4 of the patients responded. But after 1 year, when we stopped tacrolimus, the graph began to diverge. And at the end of 2 years, and again at the end of 6 years, you can clearly see 60% of the patients treated with the Ponticelli protocol had a relapse-free disease, compared to close to 30% of the patients only treated with tacrolimus. And also, if you look at the adverse events at the end of 6 years, there were more in patients who received tacrolimus, clearly suggesting that modified Ponticelli protocol in the medium term and in the long term is better than tacrolimus and corticosteroids in managing membranous nephropathy. Coming to the studies on rituximab, I would mention only the conclusion part, because most of us are aware about the studies. The Mentor trial compared rituximab versus the cyclosporine, and the inference was at the end of a year, rituximab was non-inferior to cyclosporine, and at the end of 2 years, rituximab was superior to cyclosporine. And also, if you look at the adverse events, the safety profile was better in patients treated with rituximab compared with cyclosporine. And the dosage that they used here was close to 4 grams, that is 2 grams on day 50. And again, they repeated the same at the end of 6 months if the patient did not have complete remission. The next one is the Starman trial is a deviation where they use a sequential therapy, where they use tacrolimus for 6 months and then rituximab. This is largely Spanish patients, and they compared it with the modified Ponticelli protocol. And what they found was, the Ponticelli protocol was clearly superior to a sequential therapy of tacrolimus followed by rituximab. The total remission rates, the complete remission rates, and the immunological remission rates were better in patients treated with the Ponticelli protocol. The next study, which is actually the only study which is compared rituximab versus the modified Ponticelli protocol, is a pilot study where they did a head-on comparison using 1 gram on day 0 and day 50 versus the modified Ponticelli protocol. What they reported was about 3/4 of the patients had remission at the end of a year in both the groups, The complete remission rates was better with the cyclical therapy compared to rituximab, but the difference was not statistically significant. At the end of 2 years, and again at the end of 3 years, three-fourths of the patients continued to remain remission in the both the groups. But this is a pilot study, so the objective of pilot study is to look at the feasibility and a sample size calculation, and the outcomes actually are something like a co-primary outcomes. So you cannot pay too much of weightage to the results, but yes, this is the only study which evaluated such a thing. If you look at the adverse events, also they were similar. The serious adverse events were similar in both the groups. Coming to, we have long-term data with respect to the Ponticelli protocol. Do we have long-term data with respect to rituximab? The Mayo group by Sir Fervenza had reported the long-term outcomes of patients treated with rituximab for membranous nephropathy. What they reported was 95% renal survival, that is dialysis-free survival was 95% in patients who received rituximab as their therapy, and close to 90% of the patients actually achieved clinical remissions, and somewhat equally divided, complete and partial remission was seen in about 38 and 48% of the patients respectively. Only 10, close to 10% of the patients only failed therapy to rituximab. And yes, if you look at the response rate, it's slightly delayed. We should all remember that when you use rituximab as a therapy, it depletes the B cells. When you use cyclophosphamide and corticosteroids, they also attack the plasma cells and the memory B cells. So it's important that whenever you use cyclophosphamide, you'll have a quicker remissions, whereas when you use rituximab, you'll have a delayed remission. It is important for us to note, because the patients would always come back and say that I've not achieved remission, and there will be always an itch to use a second line therapy. And in this study, and what they the predictors of poor response to therapies, the patients who actually had previous immunosuppression, that is, probably they were relapsing disease or resistant disease, or they had a bad biopsies. So that was a risk factor for poor outcome. So next one is impact of additional dosing. So when you use rituximab, what happens is you administer rituximab. Unlike when you use it in other condition like relapsing disease, relapsing podocytopathies, or steroid-dependent podocytopathies, where you use it at the phase of remission. In membranous nephropathy, you use it when the patient has got a lot of proteinuria. So whatever rituximab you administer would pass down the urine. So, this is one of the reasons why, you have very low circulating levels at the end of 3 months in patients with membranous nephropathy. Only, 60% of the patients have adequate rituximab levels at the end of 3 months in patients with membranous nephropathy. In a comparative study from the French and the Nijmegen cohort, what they reported was in patients who have an anti-PLA2R titer of more than 150, the response to rituximab is poor. And compared to the a slightly prolonged corticosteroid and cyclophosphamide therapy, where more than 85% of the patients had immunological remissions. So what the French group did was they added an additional dose of rituximab at the end of 3 to 6 months. And what they found was when they added an additional dose of rituximab at the end of 6 months, 80% of the patient had immunological remission. Similarly, 80% of the patient then went on to develop clinical remission. So suggesting that, if you give such an additional dosing at the end of 3 to 6 months, the patient's remission rates may improve. So based on this, this study, what we developed as a protocol in our unit is in between 3 to 6 months, we administer 1 gram of rituximab additional dosing to all the patients who do not achieve complete remission by 3 months. And what we found was when we did a propensity match scoring with patients treated with Ponticelli protocol, the remission rates were similar. Yes, the patients treated with Ponticelli had a quicker time for remission compared to the rituximab-based therapy. And also, the relapse rate were higher with Ponticelli protocol compared to rituximab-based therapy. And the best thing was with the adverse events. Although it was a retrospective analysis of a registry. So, patients who have come with milder symptoms or those who do not report to us for milder symptoms we would not have documented them. We did find that there was 65% reduction in the adverse events in the rituximab compared to the modified Ponticelli protocol. And yes, if you use rituximab, the risk of diabetes, leukopenia, there are less. The neutropenia is a side effect, but we did not observe in any of our patients. So Coming to the last part, or what are the newer studies that have looked at alternate therapies in membranous nephropathy is, this is a very interesting combination. Yeah, this is from the Nijmegen group from Netherlands, where they looked at a combination of rituximab 1 gram on day 0 and day 50, and low dose cyclophosphamide about 1 to 1.5 milligram per kg for about 8 weeks, and then a brief course of corticosteroid. They use it for only 3 weeks. And what they found was, close to 90% of the patients had immunological remissions. And also the clinical response was seen in 85% of the patients, and three-fourths of the patients had complete remissions. So, this study largely suggests that if you are able to use this kind of a combination, you're going to have a superior remission rates. This was a single arm study, so I don't think we can draw too much conclusion without a comparison of modified Ponticelli or rituximab based therapies. So, this is a trade-off, with respect to the toxicity with the Ponticelli protocol, and poor remission rates are like, 40% of rituximab do not respond in the clinical trials. So this is a trade-off between the toxicity and the efficacy. The second is the multi-targeted therapy. This was reported from China, where it's similar like in the kidney transplant combination of calcineurin inhibitors. It was cyclosporine in the study along with mycophenolate mofetil and prednisolone with the modified Ponticelli protocol. What they report was close to three-fourths of the patients in both the groups responded, and the complete remissions and partial remissions were both comparable. And so, this is also a promising option. This is used in lupus nephritis. I think it's also an option in membranous nephropathy. But remember, this comes with a lot of corticosteroids. So you use 60 milligrams of corticosteroids to begin with. The next important drug is obinutuzumab. I think after lymphomas and lupus, I think this is one clinical condition where there are clinical trials happening with obinutuzumab. Obinutuzumab is a type 2 antibodies, it depletes not only the B cells in the circulation, but it also depletes them in reticular endothelium. That's you have what you call as a deeper remissions, so it's a type 2 antibody. It causes the lysis of the cell by direct antibody-dependent cytotoxicity, whereas rituximab, it's more of complement-dependent cytotoxicity. This is the Orion study from Professor Rimuzzi's group, where they reported the response to obinutuzumab in patients who are refractory to rituximab treatment. And 20 patients, rituximab refractory, were treated with obinutuzumab, and what they found was 85% of the patients had remission. Proteinuria nicely dropped from 5.6 grams to 1.4 grams. That's more than three-fourths. And also there is improvement in serum albumin, and the anti-PLA2 are most of them had complete immunological remission, that is below the detectable thresholds. So this is the resistant membranous nephropathy. Then what about use in membranous nephropathy, like in the treatment naive or relapsing groups? This is a nice study from China where they looked at 21 patients with obinutuzumab and compared them with the propensity batch scoring with 1:2 fashion with rituximab. That is 21 patients with obinutuzumab and 42 patients with rituximab. And what they observed was total remission rate was seen in 95% of the patients. The difference was statistically significant as when with better with obinutuzumab compared to rituximab. Complete remission was also better with obinutuzumab compared to rituximab. Like the clinical remission, the immunological remission was also crossed 90% with obinutuzumab compared to only two-thirds in rituximab, suggesting that obinutuzumab is better than rituximab. This has been very well shown in lymphomas. Then in lupus, I think membranous nephropathy is going to be no different. We have the Majesty trial, which I think the trial is over, and Roche has reported that they have achieved the primary endpoint. I think the primary endpoint is remission rates, and that's not a surprise. But as I said, devil would be in the details. We would be keen to look at the details. What is the control arm used, which is tacrolimus, and what is the difference between the two? Well, the last comment would be on patients membranous nephropathy with kidney dysfunction. It's not a common entity. Most of the patients, more than 85% of the patients with membranous nephropathy have normal kidney function. They may be transient because of the hypoalbuminemia or excessive overzealous use of diuretics. So this is a nice trial, which is probably one of the best trials done in membranous nephropathy. This is from England, where they looked at patients with declining kidney functions treated with chlorambucil, corticosteroid, cyclosporine, and supportive care. What they found was, the best results, that is kidney protection, was that is less than that is only 58% of the patients had a 20% GFR decline with chlorambucil and corticosteroids. This is more than 80% for cyclosporine supportive care, suggesting that clearly, chlorambucil and corticosteroids, that is alkylating therapies along with corticosteroids, is better than calcineurin inhibitors and supportive care with respect to the efficacy. Yes, the safety side effects, the safety profile was better with the calcineurin inhibitors and supportive care. But if you look at a trade-off, I think if you look at the renal preservations, I think patients with kidney dysfunction or rapidly deteriorating kidney functions, alkylating therapy and corticosteroids would be the to-go regimen. Then, is there any evidence with rituximab in such scenarios? I think there are two studies, one from the French group and one from our unit, where we looked at small number of patients with CKD stage 4 and stage 5, not requiring dialysis, treated with rituximab. What we found was close to 70% in the French cohort and 50% of the other patients had partial remission and a very few complete remission. And the patients who achieved remission, they remained dialysis free for most of the times and reported to 5 years. And even in these patients, achieving immunological remission is key. Once you achieve immunological remission, most of these patients would have a significant improvement in their albumin levels and the improvement in their GFR. Proteinuria might not be a true reflection because sometimes, because of the chronicity itself, you would have a lot of proteinuria ongoing. So with this, this is my last slide where we focus on the 10 points in management of membranous nephropathy. Conservative care is important, but patients with high PLA2R titer are less likely to respond to conservative strategy. Anti-PLA2R can be used for the diagnosis and also during the management of membranous nephropathy. Even in patients with membranous nephropathy with severe CKD, that is 4 and 5, immunosuppression is recommended if the anti-PLA2R is positive. Malignancy with membranous nephropathy is generally not seen with cyclophosphamide unless the dose is more than 36 grams. Fertility is a serious issue. If you use a modified Ponticelli protocol, there is a high risk that your patients would become amenorrheic or azoospermic, because this is a disease of the middle-aged. Anticoagulation, I did not deliberately touch because we had Professor Jai stating that, when do you use anticoagulations in patients with the nephrotic syndrome? Membranous nephropathy is not different. In our unit, we use anticoagulation with NOACs when the serum albumin drops to 2.8 in patients with no risk, and patients with very high risk, we use aspirin. Additional rituximab is useful, and you can administer them at the end of after 3 months and less than 6 months. When you use modified Ponticelli protocol, please explain your patient regarding corticosteroids withdrawal, because this is a serious thing. Most of the patients cut their cyclophosphamide and do not report to us. Always use antibiotic prophylaxis for pneumocystis infections, cotrimoxazole prophylaxis for pneumocystis infection. And the last part is do not forget to vaccinate your patients prior to immunosuppressive therapy. Now we have these zoster vaccines and the other vaccines, hepatitis B. Please administer your vaccines before you start immunosuppressive therapy, because after rituximab, the response to immunosuppressive drops drastically. Thank you all for a patient hearing. I would be keen to take questions.
Thank you, Raja, for this comprehensive and excellent review of membranous nephropathy. I think you have covered almost everything. And so there are one or two, there are questions in the chat box, some of the questions, but I'd like to ask you, like patient with the moderate degree of proteinuria. So we have the patients who are in the low risk group, patient who are in the highest risk group, but in the patient with a moderate risk group, like proteinuria 6 to 7 gram, albumin of 2 or 2.5, would you like to wait? Or with the suppose the PLA2R level serum more than 50, would you like to wait for 3 to 6 months, or you would, what is the standard practice? I would like to ask others also regarding this. And secondly, somebody asked question in this, if antibody levels are low or disappear after 6 months, so would you, but the proteinuria is still persisting, would you wait for some time before giving additional immunosuppression, or you will give some additional immunosuppression? Yeah, please also. Yes.
So can I answer? Yeah.
Yes, please. please.
Thank you. So, I think it's a good question. So the question is about 7 grams of proteinuria, and I would keep it as 2.6 grams of albumin, because if it's less than 2.5, then it would move towards the high risk category. So here it is, I would put it as, if somebody has got a proteinuria of say about 7 grams and 2.6 and a PLA2R of less than 50, again more than 50, it goes to the high risk category. So if it is less than 50, what we do is we wait about till 3 months. If there is no decline in the proteinuria or an improvement in the serum albumin, after 3 months we start counseling our patient for immunosuppressive therapy. But this is in PLA2R associated membranous nephropathy. In patients who do not have PLA2 or associated membranous nephropathy, where we scrutinize them more, like it could be very much possible that they would have some of the maybe complementary medicines or some other membranous nephropathy where the probability of spontaneous remission is higher. There we wait up to 6 months in those patients, and obviously we rule out the secondary causes. And the second question is, sorry, I what was the second question?
And proteinuria even after 6 months, and when
Yeah, yeah.
the
So,
graph
uh,
is negative.
so we look at the PLA2R trajectory. So if the PLA2R gets negative at the end of 6 months, so I did not deliberately get that slide. There is a very nice study by from the Toronto Registry and the Canadian group along with the American Society, where they look at the anti-PLA2R, the albumin, proteinuria, and the GFR trajectory of patients in the Mentor trial. And what they reported was they made various models. And what they found was the model at the third month, where they looked at the anti-PLA2R trajectory and also the albumin trajectory. And the albumin trajectory and the PLA2R trajectory at the end of third month, determined the outcome of these patients. Suppose I have a patient who had an anti-PLA2R of 170 to beginning with, and at the end of 3 months, it's come down to 85, and at the end of 6 months, it has disappeared. So I would not rush to give the second line agent to my patient, because membranous nephropathy is an indolent disease and it takes time for these patients to recover, more so if they're treated with rituximab. With rituximab, the median time to respond itself is after 8 months. So it would take time. So I would wait for 12 to 15 months before I would give my next line agent if the anti-PLA2R is negative at the end of 6 months.
Okay. So any other comments, Swati, Kenar?
Yeah.
Good.
Yeah, I totally agree with Dr. Raja as well. But I have had some patients on whom the PLA2 goes away, and then the patient actually tends to relapse with worsening of proteinuria. And then, let's say the patient was at 10 grams, came down to 5, and now PLA2 is negative at 6, 12 months, but now they're up to 10, 12 grams again with low serum albumin. But PLA2 is consistently negative. So in those patients, I have often ended up in rebiopsying them. And if the pathologist tells me there are fresh deposits and they're seeing new deposits subepithelial location, then we kind of go back to that the kitchen and the sink story, that now the PLA2 is still active in the tissue, we're not seeing in the serum, and then I end up in retreating them with my anti-CD20 therapy.
Yeah. I completely agree with you, Dr. Swati. And there was also a comment like, when you have this kind of presentation where you have an anti-PLA2 or positive disappearing, but the proteinuria is still there. There are some nephrologists who feel that there could be dual positivity. So in these patients, so that is why you have one going away, but the other persistent. But to be honest with you, we have checked for all the known antigens, we haven't found. This is also our protocol. If the patient does not respond by 15 months, we generally rebiopsy. If they continue to have nephrotic and they have an anti-PLA2 or negative by indirect immunofluorescence, we don't use the for testing for immunological remission. Indirect immunofluorescence is better than ELISA testing. So if they are both negative, we tend to biopsy these patients. And if they continue to have membranous nephropathy as compared to the first biopsy, we end up treating them with the second line agent. But yes, till 15 months, we do not give any second line agents. 12 to 15 months, we do not add any second line agents in these patients.
Okay.
I have a question.
Actually, I
have
have seen
Yeah.
a small. This phenomenon, I think, when we were using modified Ponticelli, we are close to 750 patients in our registry who received modified Ponticelli regimen. But this phenomenon of having immunological remission but still an indolent disease, was not there with the Ponticelli protocol. But after we started to use rituximab, I think this phenomenon is seen more frequently. I think we have close to 50 biopsies now. Sorry, that was my comment. And please.
No, no, no. I have a comment because we see the same issue. You mentioned something about the Ponticelli and the withdrawal of steroids, and I've had at least a couple of patients where it's just been so hard to get off of the steroids at the alternate month basis. And I've had to continue a little bit of steroids with the cyclophosphamide. I think there was one question in the comment as well, how to prevent corticosteroid withdrawal. Is that what you're doing as well?
Uh, it's very common. So what I do is at the end of, I've learned it the hard way because we had one third of the patients were non-compliance because of the withdrawal symptom. So we make sure that we tell them at the end of 30 days itself, like, next month, they usually say our appetites are good, everything has got better. So I tell them like, the next month is going to be horrible. Like, it's, like, you're going to have a decrease in appetite and, your appetite would fall by more than 60-70%, and you'll find weakness. So with this we found that the complaints non-complaints has dropped to less than 10%. So that is what we tend to do. But still, we have had patients who have not tolerated that at all, and what we do is, if there is such a case, previously we did not have a choice, but now we have rituximab. And to be honest with you, in a public sector hospital, the Ponticelli protocol and rituximab, the costs are the same because rituximab is less than $100, so it's the
Yes.
same. If you take the administrative cost for administration cost for the methylprednisolone, that's 9 grams, 9 days of methylprednisolone. So I think the costs are the same. So that's what we do.
So thank you.
I want to, sorry.
Can we move ahead because we are now in time. We can, because we are 15 minutes behind time. So, Raja, can you take all other questions on the chat box? Meanwhile, we go for the next presentation.
Okay.
Yeah.
There are
Yeah,
too
only
many
last,
questions like that. Too many questions like
too many questions. So I think we won't be able to.
I think there was one was how do absorption to skin kim hair dye to get a full blown. So yeah, I think we do not know. I think this is from Dr. Javeri. So we really do not know. But what this the mercury in these compounds, like I can tell it with the Indian example, like the complementary medicines and the skin whitening creams. The mercury on the skin, and what the mercury, how does the mercury cause, one is mercury can be immunomodulator, just like gold, which was used for management of rheumatoid arthritis. One, two is it gets filtered, and what it does is it damages the podocyte and causes expression of the nel1 antigens to the circulation. So there is development of nel1 because this is almost more than 90% is nel1 associated membranous nephropathy. So the mercury cause. So these are the two mechanisms that I feel would be the reason why these patients develop membranous nephropathy. Then should mercury levels be done in all patients? I think the answer
Raja,
is
I think you can answer the questions in the chat box, I think. Yeah.
that's what I'm answering them in the chat box only. Like, I'm taking those questions. Yeah. Do we should mercury levels be done? I think yes, if there is a history of complementary medicine or skin whitening creams with nel1 membranous nephropathy, answer is yes. And um, 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 having a pulmonary thromboembolism or an RBT, does it make it very high risk? I think if you go by the KDIGO classification, it says very high risk. But I think therapeutically, it would fall into the high risk category and not into the very high risk category. If, like, we choose to give only rituximab and we don't give modified Ponticelli protocol, which we reserve to only patients who have kidney dysfunctions. Then,
I think Dr. Bansal meant that you could reply in the chat box written
okay.
answers
I'm
so
sorry.
that
I'm sorry.
Dr.
Okay.
Jane can start the
Okay.
cases. Sorry
Oh,
about
please. I'm
that.
sorry.
But this is
I'm
great. Really
so,
appreciate it. I didn't mean to interrupt, but
sorry.
just wanted to clarify.
It
No
was a great
worries. Thank you.
presentation. You covered everything very well. So now coming to the last thing, Koel. So the Koel Jain need no introduction. She is the chair of ISGD committee and professor at uh,
Carolina.
Carolina.
North Carolina. Yeah. So Koel, having some interesting case and then quick discussion.
Yes. And can you see my cases, the slideshow?
We can see the on.
Yes. Perfect.
Yeah.
So given that we're talking about membranous, my next case is actually membranous. I'm going to try to go a little bit faster. This is a 50-year-old patient of mine with a history of hypertension, comes in with like nephrotic symptoms, and had been taking some celecoxib 2 to 4 times per week for joint aches. He has had age-appropriate cancer screening. He's had a 30-pack history of smoking. Blood pressure's 137/90 and has got this edema. And if you look at his labs, he has 11 grams of proteinuria and he has 2.3 serum albumin with a creatinine of 1.2. And that's his baseline. So this is not off from his baseline. His PSA is normal in the labs. All his other infectious and other workup is negative. His PLA2R levels are 190 at this point, and he gets a CT chest with a smoking history and a colonoscopy. Everything else is coming back as normal. So no malignancy that we found. And so if you look at his kidney biopsy, I'm not going to go into the details in the lower portion, but basically he has a PLA2R staining, which is positive for membranous, with some segmental glomerulosclerosis. All of this is in stage 2. He's got some moderate arteriosclerosis, but only mild IFTA, so not severe interstitial fibrosis and tubular atrophy. So we've talked a little bit about risk stratification, and honestly, although the question says risk stratify, what is your next step, right? Like in your brain, what are you doing? Are you risk stratifying first and then deciding what treatment to do? What and how are you approaching this? And this is for anybody in the panel.
So I think for me, this will, the first 3 months are going to be critical on what the trends will be of this patient's proteinuria and PLA2R. If I know the PLA2R is 150. I really don't look at the proteinuria too much. The PLA2R to me and the GFR is probably the most important. And you do have the fibrosis degree in the biopsy. So if the PLA2R is high, I mean, my knee jerk is to just treat him. But I think if I repeat the PLA2R, say in 2 months, and if it's downtrending, it's like 90, maybe we can wait because maybe he's going to spontaneous immunologic remission. So it's not a very straightforward answer, but if you go by the criteria and the guidelines, the patient should be treated based on
And
the
Dr.
PLA.
and Dr. Bhakti, you were going to say something as well.
Yeah, I mean, I think more than the risk, I would look at the patient overall. And with this degree of proteinuria, I wouldn't wait beyond 4 to 6 weeks if the proteinuria is not coming down. And yes, I would, with a PLAR this high level, I tend to treat, yeah.
Yeah, I would tend to treat as well, but Dr. Raja's got his hand up.
So, typically in our unit, we get the anti-PLA2R along with the blood investigations, the baseline investigations in nephrotics. So by the time they have the secondary workup and everything, it's about 6 weeks. So by seeing the 190, it's 150 plus, we generally say that, you would be requiring therapy, but all we need to do is ensure that, all the secondary things are ruled out. So yes, more than 50 itself, the probability of remission drops. And they say that if it is more than 100, it's almost, it's extremely rare for clinical remission. This is based on multiple reports from Europe.
Yeah. So if you were to then, so it sounds like everybody wants to go ahead and treat, right? So what immunosuppression are you all using for this patient? Dr. Bansal, you have your hand up.
No. I was just making this thing. So I just comment on the Raja's this thing. So even the patients who are PLA2R positive with high levels, and you find there's it's a most likely it's a PLA2R associated membranous. Even if sometime you don't do biopsy, so would you still do the complete workup for the secondary causes?
So, all the secondary diseases, lupus, viral diseases, malignancy can all have PLA2R associated membranous nephropathy. Only thing is the proportion drops down significantly. So, so if you have PLA2R, it doesn't mean that you can get away with your secondary workup. Even up to 20% of the lupus nephritis class 5 would have anti-PLA2R antibodies. I said up to, not all of them,
Yeah, we tend to do it. We've had patients with prostate cancer, with colon cancer, lung cancer, PLA2R positive with membranous, so just can happen.
I mean, more also you're going to immunosuppress these patients. So it's better to have a baseline quant and hepatitis. Anyway, you're doing that screening
Yeah,
to make sure there's
that is
nothing.
always usually the viral screening, ANA, and that is being done, but not the scan or colonoscopy routinely
We
in
don't
our
know.
PLA2R positive. So that the viral serology and lipase, obviously, these are done in every patient, even any patient coming with nephrotic syndrome or proteinuria in that way.
I mean, age-appropriate cancer screening. I don't think you need to do a pan scan. I mean, I think here the patient was a smoker. So I think it's fair to do a chest
Yeah.
X-ray or even a CAT scan. That's all. Yeah.
Yeah. And then colonoscopy, remember, like, I think that's the difference. Dr. Raja had talked about how you should do at least a urine, a stool testing for occult blood. I think it really depends on how much colonoscopy is available or how easily that's available. For us, it's easily available in terms of getting a screening, so might as well do it because we can do it. But I think Dr. Raja did mention in his presentation to do at least occult blood to make sure that there's no cancer. Okay, so which agent for this patient? What do you want to do?
I would vote for rituximab with tacrolimus as a bridge till I wait for rituximab to kick in as my first line and see the response. And if my PLA2 titers are coming down and proteinuria is getting better, I'm done there. Now, if you go by the guidelines, though, the titers of PLA2 were more than 190 and high-risk patients. So if patients, if you want to go the route of modified Ponticelli, then we tend to do modified Ponticelli. And what I mean by saying that, we only do cyclophosphamide with low-dose steroids for 3 months, and then we're done. So, and we kind of looked at our patient population and compared the typical modified Ponticelli versus the shorter duration of cyclophosphamide and low-dose steroids, and it was non-inferior.
Interesting. What about you, Dr. Bagchi? What would you do?
Yeah, so we use rituximab as a first line agent unless we have high risk in the sense that the creatinine is rising. But to keep our costs down, being a public hospital, what we do is instead of the tacrolimus, we substitute that with low-dose steroids. So we give 0.5 mg per kg per steroids for the immediate effect and the rituximab simultaneously. So we've seen that it kind of brings the proteinuria down faster, and then the rituximab helps to sustain the remission. And we take off the steroids very soon, like in 4 to 6 weeks, and by then the rituximab is started taking effect,
Okay, I'll come to Kinar and Raja in just a second with the next question in the interest of time. So this patient ended up getting some CNI, ended up getting rituximab. This is a patient I shared with another nephrologist, so he lives not that close to me, so he's getting rituximab there. And I typically don't do in my second or the third sessions of rituximab 2 doses, but he ended up getting 2 doses with each cycle of rituximab every 6 months. So basically ended up getting 6 total doses. I would have probably done 4 doses. So 2 and then 1 and 1. But this is what happened. And this patient is now on CNI and rituximab. Now the UPC, he's in partial remission. Now the UPC is running 2 to 3. What do you both, Kinar, Raja, what would you do? It's not complete remission. Would you switch? Would you stay? What would you do?
Yeah.
Well, the patient, oh, go ahead.
Go ahead, Kenan, please.
Well, is the patient in immunological remission or what is the PLA2R trend?
The PLA2R after the first cycle of rituximab became less than 50, and then I think it went away. It's 0 at this point, but the UPC stayed in the 7-8 gram range for a while, and so ended up getting more and more rituximab. But now it's 2 to 3 grams. There is no PLA2R. Has been no PLA2R for over a year now. So
I mean, I've seen this, and some of these patients go into more complete remission even like 15 months after the rituximab. So sometimes you just have to be patient and do nothing. If you want, you can rebiopsy the patient, see there's active new deposits forming, but you did have a fair amount of IFTA on this biopsy. So at this point, I would just do conservative therapy and not overly immunosuppress this patient. Given the PLA2R is in complete immunologic remission. Yes, you might miss like a antigen, co-dominant antigen here. Maybe there's a NEL1 on top of PLA2R or something else going on. But time will tell you that, it's only been, what, 6 months?
No. This is every 6 months has been getting it. So 3 cycles. So 18 months of therapy, and I would say you're at the 20-month mark now.
I wouldn't go more immunosuppression. If I would change it, I would change it to a complete different modality like a Ponticelli, because you haven't hit that part yet. But I would be worried about overly immunosuppressing this patient at this point.
Sounds good. What about you, Dr. Raja?
Uh, See, if I had such a patient, so we generally wait for two, because if the patient is in partial remission and immunological remission, that's an indirect immunofluorescence showing no antibodies. So we generally wait for these patients over 2 years. If you look at the results of the recyclo trial, you will find that it was 60% at one year, 65% at 1 year. It became 75%, and it became 80%, more than 80% at the end of 3 years in the recyclo trial. So, there is, the patients treated with rituximab, they take a longer time to achieve remission. Yes, you are right in the sense that, there is some uncertainty about 3 gram a day. It can just go over 3.5 grams and the patient would be having a nephrotic range proteinuria. But if the PLA2 or by indirect immunofluorescence is negative, serum albumin is normal. So I would just continue watching these patients. At this point of time, I would also add another aspect of membranous nephropathy that I didn't touch upon, is up to 40% of the patients with membranous nephropathy treated with multiple courses of rituximab would have anti-rituximab antibodies. And there is clear emerging evidence that patients with anti-rituximab antibodies, they do not do well in the long term. That is, they have relapses, and when such relapses are treated with rituximab, they have poor remission rates, and these kind of patients do well with obinutuzumab, which Dr. Javeri said that if I have to choose and give some therapy, it would be something totally different. So I think I would agree upon that.
Sounds good. And that was my next question, which I didn't click on. So I'm going to go ahead in the interest of time with the last case. So this is a 32-year-old male, and he has no past medical history, comes in with 10 grams of proteinuria and edema, has a blood pressure which is high at 150/90, and a BMI that's 24. And other than the edema, the rest of the exam looks fine. And if you look at his blood work, creatinine used to be 1.2, 1.3 a year ago and is now about 1.5 milligrams per deciliter. Urine protein is about 12 grams. Serum albumin is about 2.6 and has oval fat bodies. All of the workup has been negative. Genetics is negative. Kidney ultrasound is normal. If you look at the kidney biopsy, has primary FSGS with 38 glomeruli, 11 with FSGS NOS, 8 with glomerulosclerosis, and moderate IFTA is also present, and diffuse podocyte effacement is present. So FSGS patient with diffuse podocyte effacement and NOS. How are you all approaching this case now? I will start with Dr. Bagchi, just because you're right there.
So for primary FSGS, we would generally stick to only steroids, 1 milligram per kg, and we tend to wait for. In all cases, we don't wait till 16 weeks, especially if the proteinuria is very. I know the guidelines say the 16 weeks thing, but sometimes by 12 weeks, if there's no trend in reduction in proteinuria, we would usually do the genetics at this point. Since this patient is already worked up and we're very sure it's a primary FSGS, we would go on to a CRI.
And then Dr. Bansal.
Yeah. No, so my initial usual approach is to use steroid, and again, as Somita told you, that after if the initial non-respond for, maybe you will not wait for 16 weeks. At 8 weeks, you will do the genetic testing, and but if the creatinine has come down, suppose there is some improvement and the creatinine has come down, then you can maybe at this stage, I would like to add either CNI or rituximab at this stage. If the creatinine is high, maybe adding rituximab, or if the creatinine is normal, then CNI, and then reducing the steroids. So that would be probably my approach at this time after seeing all the evidences. Yeah.
So Kinar, I'm going to go to you next. Sounds like you talked about multimodal therapy that you would have started. And so this patient gets started on steroids, is on conservative therapy, and is about 5 to 6 grams, in terms of proteinuria. What is your multimodal therapy at this time?
So, I mean, I would have given this patient Tacro with rituximab up front. The biopsy was pretty clean. There was not much IFTA. I think you could have, given that up front, but I would switch to Tacro and rituximab at this point. You could do plus minus pheresis. That's, depending on, your approach. But I would start with tacrolimus. Also, the other thing is I would ask the pathologist to look for antinephrine, because it's possible the immunofluorescence, the IgG, has dusting, and then it's behaving like an antinephrine podocytopathy, which will respond very well to B cell therapy.
And so, with that in mind, Dr. Raja, do you all check for antinephrine? Would you do the same? And how are you looking for antinephrine? Are you using it?
So, coming to the management of this case, I would also look at the serum albumin and the creatinine at the end of 6 weeks, 4 to 6 weeks of corticosteroids. If there has been no improvement in the serum albumin, although the proteinuria has dropped down from 12 to 6, but the serum albumin continues to remain the same, I would actually order a genetic testing at that point of time itself. That's one thing. And the second one is, if the patient has shown an improvement in the serum albumin, but at the end of 6 to 8 weeks, the patient continues to have a proteinuria about 5 to 6 grams, I would add one shot of a rituximab, because we know that it's likely an autoimmune disease. The serum albumin has got better. The proteinuria is still happening. The kidney biopsy is not bad. There is not too many diffuse glomerulosclerosis. So I would actually give a shot of rituximab, 1 gram, day 0 and day 15, because the patient continues to have proteinuria, so rituximab loss will be there. Coming to the anti-nephrin antibody, what we are doing now is we are coating the ELISA wells with the nephrin and then testing them for anti-nephrin antibodies. And the positive control for our case is we buy the anti-nephrin antibody itself and use this as a positive control. And we have validated our testing by Western blot as well, the ELISA samples with Western blot as well. But the only problem what we found was, many of the reports, they report anti-nephrin positivity in up to 60% of the patients. But what we found was, only if I take only the IgG alone, it's only 23% of the patients with minimum change disease were positive for anti-nephrin antibodies. And for FSGs also, it is largely the same. So, that's what we are, it's still it's a research limited, I would say that.
Got it.
Rather
Dr.
than
Oh, sorry, go ahead.
I'm done.
Good. Dr. Ora, so this patient gets conservative therapy, steroids, CNI, and then rituximab, which is sort of what everybody has now spoken about, but stays in this range, stays in the 3.5, 4 gram range, albumin's 3.5. What would you do next?
So if the patient had received rituximab and we're already, let's say, 3 to 4 months into it, none improvement whatsoever, then I tend to check the CD19/20 count and make sure that they're depleted. And if they're depleted, then I do want to give them some more time. And if their CD19, CD20 is repopulating, then I try to make a case for doing obinutuzumab at this point.
Okay, that sounds great. And it is 11:16. That was my last question. I'm going to stop the slide share. I will let Dr. Bansal close us out. But thank you so much, everybody, for being here and participating and engaging with us.
Thank you. Thank you very much, Koel and Kenar and Swati and Raja and Somita for excellent talks and being panelists.